Gentlemen, we're live and recording.
Thank you. Welcome to everybody that's joining us. We just opened up the webinar. Thank you very much for your patience. We're going to give a little bit of time for everybody to get logged in, and for those that are a little unfamiliar with Zoom to navigate around the application. As we're doing that, I just want to make a few announcements, a little bit of housekeeping. This webinar series is brought to you by the Washington Academy of General Dentistry. We've titled it our Stay Home, Stay Healthy CE series. We've been doing these webinars for the last couple of weeks, and our plan is to do it for another 2 or 3 weeks. I wanted to remind everyone that our speakers have volunteered their time. There is no honorarium, so we thank them very much. We also want to thank our co-sponsors and our support organizations out there. The University of Washington School of Dentistry CE is providing the CE credits. Talking about CE credits, you will receive an email in a day or 2 days from the University of Washington with your CE credits. Hold on to that. AGD members, we will report your CE to the AGD on your behalf, but don't be looking for that on your transcript in the next week or two. It's going to probably take a little bit longer than that. Some of our webinars have well over 1,000 people on there, and even though things are automated, it takes time for us to do this. We have a small group of volunteers, our executive director, Valerie Bartoli, and one of our panelists, Dr. Gary Hayamoto, are helping put this on. My name's Dr. Tim Hess, and we're here from the Washington Academy of General Dentistry. We'd like to thank our other AGD members that are joining us from Arkansas AGD, California AGD, and Texas AGD. We want to thank the members of the Canadian Academy of Restorative Dentistry and Prosthodontics for co-sponsoring this, as well as Comet USA, Patterson, and our local dental societies, the King County Dental Society, Pierce County Dental Society, and Snohomish County Dental Society. Now, as you see the flyers that are going by, you'll notice that some of these webinars have already happened. We're just keeping those up. So you can see what webinars are actually going to be available to you on YouTube. So if you go to YouTube and go to Washington Academy of General Dentistry on YouTube, you'll be able to find our webinars, the ones that are up. After a webinar is done, it takes us a few hours to process that so that it can be displayed on YouTube. So give us a little bit of time, and we'll get that up there for you. Each flyer for upcoming speakers has a QR code. Please, you can use that QR code. It'll take you directly to the registration site. If you have problems with that QR code not working for you, just simply go to washingtonagd.org and you'll be able to see our lineup of CE. Every day we're adding new speakers, so if you get on there and you're not seeing somebody that you know is coming up, just log back in a day or so. So we'll get that back up there. All righty, it looks like the participants are still ticking up here, so we're just going to give it a minute or so more. Please play around with the Zoom app there. Take a look on your upper right-hand corner there, see how you can switch different views, because if you don't have a view that's working for you on your Zoom app, there's nothing we can do on our side. It's probably your side, okay? This is going out in a standard format, so please play around with the app. If you get knocked off, just log back in. You're not going to hurt anything. So again, you know, we want to thank all our clinicians that have donated their time. There's been some really great presentations. Leanne Brady, Elaine Ochi, who is, you know, a good friend, and Dr. John Nosti here, he twisted his arm so he would join us. Very, very pleased that John Nosti is presenting today. He's going to do a presentation that I saw in Chicago at the 2020 Academy of Operative Dentistry. Just a gorgeous presentation. So I think you'll be very pleased. Again, the CE credit, these are all free webinars. And yes, you can have your staff members watch these CE webinars. You can also have non-AGD friends join you as well. This is open to everybody. So again, CE credits will be emailed to you in a few days. Now, it may take till Monday or Tuesday for you to see those emails. Look for something from the University of Washington School of Dentistry. For our AGD members, we will be reporting your credits to the Academy of General Dentistry on your behalf. Those credits will show up on your transcript in probably 2 to 4 weeks. Alrighty. It looks like the majority of people that have registered are joined us now. So just want to thank our sponsors one more time. The Washington Academy of General Dentistry Stay at Home, Stay Healthy CE, co-sponsored by the University of Washington School of Dentistry CE, Seattle King County Dental Society, Pierce County Dental Society, Snohomish County Dental Society, Comet USA, and also Patterson Dental. It gives me great pleasure to introduce Dr. John Nosti. John Nosti graduated from Rutgers School of Dental Medicine and went on to pursue an extensive postgraduate education in cosmetic dentistry, occlusion, temporomandibular joint dysfunction, and full mouth rehabilitation. He practices with an emphasis on functional cosmetic dentistry in the southern portion of the state of New Jersey. He holds fellowships in the Academy of General Dentistry, Academy of Comprehensive Aesthetics, and the International Congress of Oral Implantologists. He is currently the clinical director for the Clinical Mastery Series. Outside of his private practice, he has been a regular contributor to both Dental Town's online learning platform and Dental Town magazine. John has been published in the Journal of the American Academy of Cosmetic Dentistry, Inside Dentistry, Dentistry Today, Dental Economics, and ADA State Component Journal. John shares a passion for nutrition and physical fitness with his wife, Jen, and has numerous certifications in personal training and weight management through the American Council on Exercise. Along with his wife, Jen, he is the proud father of his daughter, Isabella, and his son, Anthony. Dr. Nosti, thank you very much, sir, for joining us.
Thank you so much, Tim, for having me.
And I'm going to stop sharing here. Hey, before we get started, would you just tell us a little bit about your Clinical Mastery Series, just in case we don't get a chance to speak about that?
Absolutely. So I do have a slide just to talk about that, but the Clinical Mastery Series is basically a continuum that is a centric relation occlusion-based continuum that really is geared towards teaching doctors how to do more functionally driven cosmetic dentistry in their practice.
Terrific. All right. And you'll have information where they can take a look at your series and all that with your slides?
Yes, I have a slide or two based upon that.
Beautiful. Well, thank you very much. I'm going to just remind everybody, if you have questions for Dr. Nosti, please put them in the Q&A section and we'll get to them. Do not put them in the chat section, okay? We won't get to them if they're in the chat section. So Q&A, and we're going to leave the Q&A to the end of Dr. Nosti's presentation. And so don't expect your questions to be answered immediately. Thank you, Dr. Nosti. I'll mute myself.
Thank you so much, and thank you for everyone joining tonight. Hopefully you either have a cup of water, a glass of wine, maybe a cup of coffee, and let's get into really talking what we love, and that's dentistry. So tonight I'm going to get into, or today, depending on where you are in the country, we're really going to talk about minimal and no prep anterior all ceramics. Gonna get a little bit into about material selections and really treatment planning these cases and what we should look out for. So as Dr. has said, thank you so much for the introduction. I just want to let you know I am a full-time practicing clinician like you are. I participate with some insurances. Yes, I am a educator, but for the most part, I am a full-time practicing dentist. So I think that's really important to understand. I want to thank my family who, right now they are sitting in the other room, keeping our dog quiet, making sure that, we have some time to talk about dentistry. And I always want to thank my family who support me and sharing my love for dentistry. And I don't know about you, but I think if we think positively about this time that we have, right now with at-home quarantine, I mean, I'm no longer a dentist really this week. In the past couple of weeks, I've been currently a first grade teacher to my son, Anthony, which has just been an absolute ball. And, hopefully he'll look back and remember the times that we spent doing this together. My daughter, Isabella, for those of you can also maybe understand and relate. She is a freshman in high school. So, she doesn't really need so much coaching from her parents at this point in time, but I think her too, she's really loving all the time that we're getting to spend together. And then I do miss my clinical mastery family, which we do travel around the country and we teach continuing education seminars that, as I said earlier, are centric relation based. And we have an occlusion series that's really geared towards teaching you how to do more aesthetically driven cosmetic dentistry in your practice. All of our courses are hands-on. And you can check them out at clinicalmastery.com because we have a lot to talk about. I do want to let you know that our mantra, as you can kind of see from my banner behind us, is rock the drill. So, there's not a lot of, really people talking about how great the field of dentistry is and, really what an unbelievable opportunity that we have in this field. And we just want to really let you know about that. For those of you who would like a copy of my presentation, even though this is being recorded, if you would like a handout, you can go to clinicalmastery.com and then scroll down on that page. And when it says want to learn more, just click on that button right there. And then this will pop up. And then in that message, just say, please send me John Nosti's, Washington AGD webinar presentation. Now give that a little bit of time because, everybody's working from home, but we will be able to get that over to you. So without further ado, unlike just being a cosmetic dentist, as I said earlier in my bio, I'm a functionally driven cosmetic dentist. So, I kind of made a name for myself in my area by restoring patients who presented to my practice with an extensive amount of wear. Sure, they might have had some cosmetic desires, but really it was a lot of functional issues. And we can see that, when we treat these patients, we can really do an unbelievable job with aesthetic dentistry that's available to us nowadays. Patients like Lee, who comes in and, he was told that there's not much that, doctors can do for him. He has a lot of wear. He's unhappy with his smile. Even he shared with me, he thought this was affecting his business in that because he didn't want to smile very often, he felt people thought he was not trustworthy. So, he literally felt his life was transformed by having some all ceramic dentistry done. And patients like Helen, who come in with temporomandibular joint disorders associated with having an extensive amount of breakdown. And we can restore these patients and really give them an absolute beautiful smile. But what's really interesting is when you have these after pictures, they just look like before and after pictures. And no one really knows the story about these patients. And when you sit down and you archive these cases and you put them on your website, patients don't know whether or not these people came to you because they wanted a smile or they needed a smile. And I think that's pretty important to understand. And especially when we get back from this quarantine, is that there's still going to be people like we can see on this screen who need our dentistry, not just patients who want our dentistry. What's really important is that we take cases like this, we understand, we know what caused these cases to break down, and that when we do an aesthetic enhancement on these cases, not only do we want to be conservative because these patients already broke down and wore down their dentition, but we want to have a beautiful, outstanding result. So we want to be conservative and have a great result. You know, patients like this who come in and they might have some occlusal breakdown. They may have a lot of interproximal restorations that you can't see from the facial surface. You know, we still want to give them a fantastic result that we know is going to last for a long period of time. So, and I know as time goes on, we want to be more and more conservative with what we do for our patients. So where did this really minimal and no prep concept come from? And what manufacturers and who was really leading the charge? So when we talk about no prep, you know, veneers, when I grew up in dentistry, these are companies like Lumineers and Glam Smile and Viveneers and Nano Veneers. And really, the minimal and no prep concept came from doctors and patients' unwillingness to want their healthy tooth structure removed. And if we look at like the history and where we've gotten to, you know, some of you who maybe you haven't been in practice for a long period of time, you might not even remember Lumineers, but this was extremely popular in their marketing in the late 90s and early 2000s. So popular that Lumineer ads appeared not only in People magazine, but on the back of a lot of People magazines. And really, patients didn't call your office asking for veneers. They called asking for Lumineers. So, you know, there was a lot of marketing that was out there for them. You know, but if we really looked at it, some of that marketing, I looked at it, it really turned off dentists because, you know, it kind of led with a little bit of fear marketing. And their marketing said, hey, you don't need any shots. So you don't have to worry about being in pain. And you have no removal of painful enamel. Now, I don't know about you, but I don't really think enamel is painful to remove. And last time I looked, you know, my enamel is not really painful. It's really the underlying tooth structure that is painful. This is their marketing, remove painful enamel. And one of the really bad points of their marketing that I thought was a great injustice, because it also gave dentists an idea of what they should and shouldn't be doing, was their statement of there's no need for unsightly acrylic temporaries. And I think that's really bad because, you know, when we look at it, we all want to trial the smile out. And, you know, temporaries are a trial smile, both aesthetically and functionally. And the last thing you want to do is just go from start to finish without your patient even really getting a chance to test out what their smile is going to look like. But that was in their marketing. And furthermore, they really talked about it's as easy to do in 2 visits. So, you know, what really happens to Lumineers? Well, you know, I look at it, they were a victim of, you know, just industrial marketing and what happens. And they're here one day, and then the next thing you know, a band, the Lumineers, comes along, and, you know, they have this huge record contract, and their band takes off. And all of a sudden, when you start looking on internet for Lumineers, all you see is information about the band, and it's really difficult to, you know, see anything about Lumineer ceramics anymore. So literally overnight, they went away. And I really want you to get out of this presentation that cases in your practice, sure, there are cases that are completely no prep, and I'm going to show you them. And there are cases that will require prep. And I don't want you to think of this anymore about flipping a coin and which one of these are you going to do on your cases. I really want you to understand that in all of our aesthetic dentistry, prep and no prep can be married together. And we're going to go over this with, you know, a couple cases tonight, and that I'm going to highlight, you know, when I did minimal prep, no prep, and even taking this beyond just these 3 cases that came to my practice. So everything always starts out with, you know, your facial analysis, your dental label analysis, and your dental analysis. And we really want to look at what's really important here as what's really going on with our patient. You know, we want to basically look at, you know, what's going on with their occlusal plane, their facial proportions, where is the position of their incisal edge? What is their occlusal plane orientation? Because that many times has us taking a look at, is this a single arch or a dual arch case? What are the proportions? And of course, shape, shade, and texture. These are all things aesthetically that we want to look at with our cases. Likewise, we want to look at our cases functionally. And functionally, we have to look at it. Does this patient have a temporomandibular joint disorder? Because studies show that once you lose the disc between the bone of the jaw and the bone of the skull, you are going to have some changes that occur to the occlusion. Some deal with immediate side shift, and some deal with both loss of vertical dimension in the joint, and thus patients are more prone to anterior open bites. If we want to look at functional analysis, what's our occlusal plane? Do we have anterior guidance? How is your condylar pathway, our occlusal SPE and curves of SPE and Wilson? And what relationship are you dealing with? Maximum intercuspation, centric occlusion, centric relation, and neuromuscular dentistry. I'll just tell you, just as a quick note, anytime I am doing more than 3 units of indirect dentistry in my practice, I will make sure that I have a patient who I'm going to restore into centric relation. So I'm going to make sure their maximum intercuspation and centric occlusion are equal to one another. So, if we look at, further and analyzing our cases, it's important to also look at a parafunctional analysis of our cases. And a great textbook to really understand this in detail is a book published by Quintessence that's called Bruxism Theory and Practice. And it really goes over the differences between attrition, abrasion, and, when we're dealing with parafunctional issues like crossover and lateral intrusive crossover, and when we're dealing with protrusive bruxism, because it's important to understand that these bruxism patterns that we see on the right-hand side of the screen, if we're going to fix these patients, it's important to know what allowed the patient to get there to begin with. Because if we don't correct this functionally, your patient is then potentially subject to break those restorations that you're going to put in place. So we want to make sure we take care of this. And then we also see not only issues with wear and attrition, but we can also see chemical wear. And those come from things like GERD, bulimia, citric acid fruit mulling, paramolysis, and even swishing carbonated beverages. So these are patients that we can also do some minimal no prep restorations on. So when we look at our exam, we want to perform a thorough comprehensive examination. We want to do a TMJ exam, a muscle exam, range of motion, and lastly, we look at our teeth. And then depending on what you find in each one of these boxes is going to give you basically a green light, like your patient's ready to go. Maybe it gives you a orange colored light, which, in New Jersey, that means go faster, right? When we see the orange colored light, but mostly across the country, that means like, that's a warning, like maybe slow down, or maybe this patient is a red light for whatever disorders that they have in these boxes. And then maybe that's a case that you want to stop. So let's look at our no prep case selection. So we look at what our ideal case selection includes is proper arch alignment. So you want to have a great arch alignment. Great no prep case selections are people who want a color change. And of course, tetracycline, depending on how dark it is, it's limited. Patients who need to have their teeth lengthened are ideal candidates for no prep restorations. Closing small interproximal spaces is another great candidate, provided that their teeth are not triangular shaped or bell shaped. And collapsed buccal corridor is a great indicator for no prep case selection. And we look at it many times when you're dealing with a smile design that you're extending back to the premolars. Those premolars almost always in those cases can fit this category. And of course, wear, as you talked about earlier, but you definitely want to determine the source first in order to fix these restorations. And then lastly, direct resin bonding replacement, where you can take off the resin bonding and then add it back with porcelain. Some contraindications are patients who have rotations or crowding, extremely buccally displaced teeth, because teeth can already be in the correct position or too far forward. So if they're buccally displaced and too far forward, the last thing we want to do is add a ceramic restoration on it. Teeth that are too far lingually displaced, that's also a contraindication, because even though you can add facially to this tooth structure, you might not want to because of the resulting contours that you're going to get out of that restoration. So I said earlier, bell-shaped or flare teeth are a concern because you cannot get the porcelain down to the gingival margin in those situations. Teeth that are severely discolored, that's a concern because in no prep restorations, you're not really finishing the margin that far in approximately. So that's going to be something that shows up on a patient. Large spaces we cannot treat because you're going to be left with an overhang. If your patient wants to close black triangles, that's a conversation you should have ahead of time, because you're not going to be able to close a black triangle with a no prep restoration. And then really attempting any severely drastic color change. So if you're going like 7 or 8 shades, like an A4 to a BL3 or a 1M2, that's going to be pretty hard to do with a no prep restoration. In a case like this, someone who presents to your office with a single central, this is not a situation for no prep restorations. Patients who come in with crowding, and especially associated with when they have anterior and posterior teeth that have 4 and 5 surface direct restorations. And you can see that on the laterals. It might be hard to see on the centrals here, but from the back, these teeth are heavily restored. So if they're heavily restored, rather than doing orthodontics, and then restoring them, this could be a situation you can restore right from the get-go because the teeth already have so much composite in them. Let's look at the materials available. And, we won't go back to lumineers. And lumineers are still available nowadays. Their advantages are, not so much anymore, but they had a name recognition. Their manufacturer marketed them greatly. So that was a huge thing. You had to take advantage of the fact when they were on the back of People magazine, that's free advertising to every dentist. So that was a great time. Some disadvantages associated with it is, it was really lack of doctor and lab interaction. I mean, you had no idea what ceramist you're going to work with. You got a different ceramist every time you sent a case in. So that was pretty hard to have rapport over a period of time. So you had no choice of ceramist. And I really look at it, not only did they have a lack of vitality and they really didn't look that great, but there was no long-term studies on lumineer porcelain. So that was a really disadvantage in my mind. Then we have powder and liquid. And some powder and liquid that you would know would be like feldspathic porcelain. Huge advantage of feldspathic porcelain is within the restoration itself, you have the ability to modify opacities and translucencies within one restoration. So for instance, powder and liquid is a great restorative material for tetracycline staining. You can add internal coloring and layering. You have the ability to work with an artistic ceramist. And I'll tell you that might be a little bit of a downside because the only people who are going to do this is going to be an artistic ceramist. So it could be a little bit hard to find. And aesthetics really are key with powder and liquid. They really do look unbelievable. Some disadvantages could be marginal integrity. And this is what we see in studies. Strength. Now, not that they're not strong, but they're not as strong as what other materials we have available. Same thing with wear compatibility. Nowadays, feldspathic porcelain is not like Vita Alpha from the 70s and 80s. So the wear compatibility is there, but it's still not as good as what other materials are available to us. And I will say the lab fabrication on these is difficult. So anytime something is difficult in the lab, how does that translate to you? It translates to it's going to be expensive because it's hard to do. And it's going to be difficult to find someone who does it well. Pressed ceramic. So what are some advantages of pressed ceramic? We have strength. We have the ability to design the contours before it comes to glass. So this is like a lost wax technique where they can wax it up, they can contour it, then they can press it to ceramic. So they can design it in wax before they actually put it into ceramic. That's a great advantage. So you can measure the thickness throughout the process, which is difficult to do with powder and liquid. You have great marginal integrity. You have great wear compatibility. And you do also have the ability to work with an artistic ceramist. One of the benefits that I'll see also to press ceramics, depending on your choice in press ceramics, is it's ideal with wear cases. So if you're trying to regain anterior guidance, or if you're going to change vertical dimension, press ceramics are really where it's at. Some disadvantages are, it's going to be monochromatic because it's pressed in an ingot that from top to bottom, or incisal edge to gingival margin, that ingot has one chromatic appearance to it. So it's monochromatic unless they cut back the incisal edge. Press ceramics, it is difficult to cover gray or discolored teeth. And you hear a lot of doctors talking about that in press ceramics, that they feel that maybe their end result is, a gray, more of a gray appearance to their color. And lastly was fabrication. Sorry, I jumped the gun with my button there, but the last disadvantage there was lab fabrication. And to me, when I say lab fabrication, I really mean that in minimal prep cases and no prep cases, because for the most part, the majority of your labs, your dental labs out there, they're doing press ceramics. So let's look at case selection. So case selection we want to look at is preoperative shade, and how vital and natural do we want the final end result. Now, many of my patients say, well, doc, I'll leave that up to you. And this is really where the trial smile comes in, because they say that at first until their trial smile goes in. Then when their trial smile goes in, what I almost always hear is, these look great. I love the size, I love the shape, but I want them whiter. So that's one of the huge advantages of a trial smile. But something that you want to talk to the patient ahead of time. Not that I ever recommend you show a patient a shade guide, because if you show a patient a shade guide, they are automatically going to choose the whitest shade that they see on that shade guide. So don't ever bring out the shade guide. Just you can choose a shade and then show that patient that shade. We can go 3 to 4 shades brighter and still maintain a natural appearance with a no prep restoration. And what's really important to look at it is the profile of the patient. And what's ideal is teeth that are upright or maybe slightly retroclined. Teeth that are proclined are already in the correct position. So it's going to be difficult to then add more to that. So teeth that are slightly upright or slightly retroclined are great. And we want the arch form, as I said earlier, close to ideal. So here's where the lumineers came in. And they said, really, their process was minimal communication, only 2 appointments. You send in your impressions and you get back a smile. What was really needed when you did this was great impressions. Lumineers didn't necessarily ask for a face bow, but what I would absolutely recommend to you is always sending in a face bow transfer. You either mount the model yourself or use something like a Coy's facial analyzer, maybe even an AD2 bow, which with the laser attachment to it allows your face bow transfer only to be about $1.25 on a plastic jig versus a whole ear bow jig. A stick bite works really well. You want to send in the 14 AACD photos so the lab can really see every part of this patient. You want to show them the tooth shade and the final shade that you're going for, and then request any special characteristics. And not to go into depth of all the photos, it's just the AACD criteria. That is the list, and these are basically what they look like that you're going for in order to document every one of your cosmetic cases. So some advantages of that minimal communication. Yep, it's quick and easy. It's direct competition with lumineers. And if you work with a really talented ceramist, you can get a great result. But honestly, this has a lot of disadvantages, and I don't recommend that you do this because there's really no smile design being done, and you have no cosmetic and functional test of your trial smile. So getting a trial smile and a wax up is key to any cosmetic case. So then you can have moderate communication. And this can work really well, and it's still 2 appointments, but in your first appointment, you're going to do a smile design. And this could mean that you can do direct resin addition to the patient's teeth and literally see and shape that you're going to do. But this takes time, and it takes additional records. You're going to have to do the mock-up, or let's say that cosmetic smile, on the patient intraorally in their mouth. And really what I recommend you do is you communicate the length of the centrals, laterals, and canines. You want to get the smile line. You want to get their incisal edge inclination, their profile, and you want to dictate where the buccal corridor is going to be. So that, and of course where their midline is. But that does require a lot of work. Some advantages is, for some doctors, it's quick and easy. You can bring the patient in, you can add direct resin, and you're good to go. And you're in charge of, for the most part, where their design is. And you're also giving a lot more information to your ceramist that they have to go by. Some advantages that you still are not doing the whole smile. The patient doesn't really get to go home with this for the most part. So there's less input from the patient, and this does require more time on your side in order to get this done. So I look at it, what's really optimal communication and what really should you be going for in your practice? And this is really 3 appointments. So the first appointments are going to be records. You could do a minimal mock-up where you're just designing where the centrals are and just length of it's going to be 3 appointments: records, mock-up, and then seat. And the best part about this is the second visit where you're going to place the mock-up, that allows that patient, they can go home with that. They can take it for a test drive. They can look at their smile in areas of their car, in their bathroom, in their mirrors, in their bedroom, all these different areas. And more importantly, they can show whoever are the people in their life who are going to help make that decision. So it allows for a lot of patient interaction and feedback. So other advantages, the patients get to preview their smile in their patient. There's a lot more feedback to the ceramist, a lot more feedback to the patient. And the best part about it is once you have dialed in that mock-up, you can ensure exact replication into their final ceramics. So there's no question as to, there's no prep and pray here as a lot of people talk about. It's an exact duplication. Some disadvantages, you do have a little bit extra expense from the wax up. And for some people say this is a little bit more time intensive because it requires that secondary visit. But I would say consider the time you would spend on your direct resin mock-up and just transfer that into that second appointment where you're just adding it into the patient's mouth. And I really look at it, this is not a whole lot of time spent in my practice. So let's look at my patient, Lou. So now Lou is 20, just graduated, 23 years old, referred by his mom, who I performed. And, his mom and himself were both concerned about the amount of wear that Lou had on his teeth. So if we just take a look at some photos, we can see intraorally at his occlusal arch form, some concerns that we have here. So the first things I want to point out is that, he's got diastemas distal to the canines. Now, these aren't big diastemas, but they are still diastemas. And if we take a look at the tooth on the right-hand side of the screen, so tooth number 6, if you're from Canada, that'd be what, the 1-3. So if you have tooth number 1-3, that is a bell-shaped tooth. And in order to get porcelain down to the gingival margin, we would have to prep that much tooth structure off in order to have a direct straight insertion on this tooth in order to close down that interproximal space, that diastema. So he's got some pretty big diastemas. The diastema between the lateral and central, that's not so big, and those teeth are pretty much straight. So if need be, we could probably close down that space. But really the big concern, and what did I say is a contraindication to no prep, is his arch form is not ideal and he's got crowding in place. So these are some things immediately I bring up concern. So if we look at the problem list, we say this patient's unhappy with his aesthetics. He has worn dentition, he's got wear into dentin on his maxillary 6 teeth, which is, I would say that's excessive. Anytime you have dentin exposure, that's the line in the sand that I draw that something has to be done. He also has compensatory eruption of those teeth, so they've erupted in order to keep the incisal length basically where they were before. But he also has anterior crowding and spacing, so that's another problem. Added to that problem is his mom doesn't want his teeth prepped at all, or very minimally. So if we look at these things, we're basically going to come up with a treatment plan. And his treatment plan is going to be either A, orthodontics, and then evaluate for no prep restorations, or B, prep and restore. So, with a little bit of talking, I, talked to Lou and his mom, and I said, I really think that I can set this case up to not have to drill on his teeth at all if we do orthodontics first. And that to me is a huge advantage of orthodontics. So in my office, in order for orthodontics to come in, orthodontics has to limit the amount of restorations I have to do, or restoration to do a lot more conservative in order for you to have the added expense of orthodontics, and then likewise, the added, for the rest of your life, long-term retention, especially an adult. So, we look at Lou, and we can see his teeth are now canted, but that was intentional, as my discussion with the orthodontist. So my goals from ortho with this case, when I communicated with the orthodontist, and the orthodontist, I will say, hit it out of the park on this case, is my goal was to eliminate the crowding and spacing. I wanted none of that present anymore, because we wanted an ideal arch form in order to have no prep restorations. And when I told him about, he asked me, where do I want the incisal edges? I said, well, I'm not really concerned about the incisal edges because we have an uneven amount of wear present. What I want you to do is I want you to idealize the gingival zeniths so that we don't have teeth that look like they're longer and shorter because the gingival zeniths aren't lined up correctly. So we want to idealize the gingival zeniths. And what a plus would be is that if the teeth ended up in a slightly upright position or retroclined, that would be ideal. But really I was looking for slightly upright on this case. So Lou went through ortho. It took only about a year in order to complete, maybe a little bit less than a year, I actually want to say. But now we have, some maybe different problems that we see from what we had before. So this is what he looked like when he came out of ortho. The gingival zeniths are lined up. We can see that even if you look at the lateral incisor on the left-hand side of the screen, we can see that lateral is now longer than the canine, obviously longer than the lateral on the arch opposite side. But we can see from his arch form is now ideal. There's no spaces, there's no rotations or crowding. It's like, this is a perfect situation to have a no prep case setup. So now he's still unhappy with his aesthetics, because some people say, well, why not just bleach his teeth? Well, if we bleach his teeth, sure, they'll get whiter, but he's still gonna have worn, short teeth. He's still gonna have a reverse smile, because how we set up the teeth orthodontically with the gingival zenith. So we still have those concerns present. And now he's got a collapsed buccal corridor. Sure, there was a little bit of that before. And now that he's a little bit happier with how his teeth look, he's really smiling. We can see that he's got a collapsed buccal corridor. So all of those things are in place. So now we're going to take our photos, and we can see his profile that's present there. We want to send that to the lab. And every time I do this, when it's a no prep situation, the lab gets 2 sets of my pre-operative impression. So we take 2 sets of impressions. This way the lab can work on both of them and compare the 2 to make sure that they're accurate. So the lab really wants to be accurate here when they're putting that much time into no prep restorations. And we're looking for basically an OM2 as a final result. Now, the other thing about teeth being slightly upright is that even though his teeth are pretty white, they will never look that white in person because teeth that are slightly upright are basically in a deflective versus reflective position. Teeth that are proclined reflect light, they look lighter. Teeth that are upright or retroclined deflect light and they look darker. So from this situation, you know, we brought Lou back in, and with my Siltec, we just added Luxatemp and put it right in position over his teeth, made his teeth longer. We still had some issues with the mock-up that I'm going to show you as we get into a little bit close-up pictures. And, you know, his thing was, I like the length, I like how broad my smile is. He was like, but I still want them whiter, which a lot of people say. So again, Siltec, it was just filled in with Luxatemp, went right in place and just peeled it off. And this was basically shrink to fit onto his existing teeth. If you ever have a question on the shrink to fit technique, you can go to Dental Town and go into the cosmetic section of Dental Town. And right in the cosmetic section, pinned to the top is a thread called the shrink to fit technique. And on that, I detail the whole start and finish process on how you could do the shrink wrap technique on not only cases like this, but even minimal and even full prep veneer cases. So if we look at his smile, we can see that he's got triangulation that we don't want to replicate into his final ceramic. So that was really one of the things that I did not like about his mock-up. So when I presented this case at the Academy of Operative Dentistry, some of my reviews say, you know, Dr. Nosti did not show any no prep cases. And I think that's because this picture really confused some participants in the room. The top model that you see there is his pre-op model. The bottom picture that you see there is what the lab did to his model in order to ditch these teeth to fabricate no prep restorations. There was zero preparation done to lose teeth. Even though it might look that way, just from how the model is ditched and how they scored where they're going to place the margin, there is no prep. That was all done in the lab to where they wanted to finish the margin. And all they're doing there is they're ditching away the gingival area and they're leaving a portion of the, like this, not to say the CEJ, but they're leaving the area where the two structure meet the margin, and they're highlighting that in order to allow these restorations to go equigingival distant. So it's important to understand there was no preparation done to lose teeth. Let's get into a little bit about materials. So let's look at the flexural strength. So we look at feldspathic. It has a flexural strength of 100 to 150 megapascals. Ceramic layered over zirconia, 100 to 150. Ceramic layered over metal is the same. You know, lucite reinforced in its monolithic form, and that would be like something like IPS Empress or Authentic. That has in studies 200 to 220 megapascals, with the average in many studies being 185. Lithium disilicate like LisiPress and Emax, that has 500 megapascals. And solid zirconia like Bruxer, like the true 3Y zirconia, is 1000 megapascals. What's important to understand is any time you cut back and layer a ceramic, so ceramic over whatever, is going to be about 100 to 150 megapascals. So feldspathic, which is always going to be layered, is 100 and 150 megapascals. It's aesthetic. It must be as adhesively cemented, so you have to bond, not just a pseudo bond like Reliax Unisem or Speedsem, anything with sem in it. Those are basically self-etching resin cements or self-adhesive resin cements. That's not bonding. And huge huge benefit of feldspathic, as I said earlier, is the ability to modify opacities within the same ceramic. So these are really great for no prep restorations. Empress has a strength of 85 to 220. Unless you cut it back and layer it, then it's going to be that 1 to 150. As I said earlier, it's aesthetic. Out of all the pressed ceramics, Empress has the longest research history of any pressed all ceramic. It must be adhesively cemented, just like feldspathic. So that's one of the other negatives for Empress. It's beautiful, but you have to bond it in place, and it's not recommended for bridge work or molars full coverage. You know, where do I use Empress in my practice? If, you know, and I kind of use the acronym, if you're a, you know, pretty female and you don't have a lot of functional issues, you're getting Empress. That's a beautiful restoration. Some single anterior crowns will use Empress. Veneers and minimal prep veneers, I'll use Empress. Emax came along, and really their name, how it was derived from, is Empress to the max. That's why it's called Emax. So Emax has a flexural strength of 500 megapascals. Unless you cut it back and layer it, then it has the same as all the other ceramics. One of the great things about Emax is you can conventionally cement it or adhesively cement it. So if it's thick enough, that's where that asterisk comes in, and the thickness is 1.5 millimeters at the occlusal table, you can use Fuji SEM, Speed SEM, Ultra SEM, you know, any one of those SEMs, you can use that to adhesively cement it. So it's strong, it's aesthetic. Emax is the most studied all ceramic. So Empress has the longest research history. Emax has the most, because when it came to market, everyone tried to put this down and say it wasn't that great. Everyone ran studies on it. Of course, Ivoclar ran a lot of studies on it as well. So there's a ton of research on it. Conventional cementation at 1.5 millimeters thick or greater. If your occlusal table is under 1.5 millimeters thick, you want to adhesively cement it. So you want to bond that as well. So, you know, this has a lot of, you know, really great areas that you can use it in your practice. Most of my posterior dentistry is Emax. Bridges are Emax. No prep restorations, a lot of them are Emax. So it works out really well. Emax is the workhorse for my full mouth reconstructions where I'm changing vertical, anterior and posterior bridge work if I'm replacing a premolar, inlays and onlays, and of course, screw retain implant crowns. A lot of that is Emax in my practice. Zirconia, of course, it came along and it changed what we're doing in dentistry. You know, I don't want you to think I don't like zirconia. Zirconia is great. But where I look at it, as zirconia is great for a bridge substructure, and zirconia is great as monolithic restorations like a screw retain prosthetic. That's changed the game in our implant pros, where zirconia came along. You know, so it's monolithic, it works great. It can be used in bridge substructures and all bridge works. I see a lot of people saying you can use it for inlays, onlays, and veneers, but I really want you to, you know, think about that as to, you know, what does the research history show on the ability to bond in zirconia? It's not really there yet. I'm sure in the future we might show that, but there's not a lot of history on it. It works great for implant abutments, implant crowns, and really for screw retained FP3s, which are like those hybrids, implant hybrids, works out unbelievable. But here's a situation, a patient came to my practice with the veneer off. And believe it or not, these were fabricated out of zirconia. And the patient said that, you know, they fell off numerous times. So you can see there's no retention built into it. And really, when there's no retention, you're really relying on your ability to bond to two structure. And you're not going to be able to bond in a zirconia veneer like you can like an Emax veneer. So I see no advantages in zirconia for in that area. So getting back to Lou, you know, we did his trial smile. He went home with it. He was able to wear it for a period of time. And now he's coming back in and he's ready to go for his final restorations. So anytime, you know, I take a case where there's been no prep at all done to the enamel, the first thing we're going to do is we're going to use a micro etcher, and we're going to micro etch his enamel. And then I do what's called a tack and wave technique. And, you know, for the limited time that we have here today, again, you can go to Dental Town, and this is all free, and you go right to the cosmetic section, right there, tack and wave, inserting the maxillary 10, and I show you a step-by-step process on how I insert my veneer and all ceramic cases. So getting back to Lou, you know, this was Lou's start. After ortho, I should say. This is where his middle treatment was after ortho. This is what his teeth look like. And here's with his felspathic restorations. You know, we lengthened his teeth, we made them brighter, we brought back in some guidance, you know, with that. And this was a case that was done by Nelson Rigo and Regal Smiles in California. And here's where Lou started. And here's where Lou finished. Made him whiter, brighter, but more importantly, you know, he got back some of the length of tooth structure that he wore down. So this is also a case, not only do we want to build it functionally with anterior guidance, but because he had ortho ahead of time and he's going to be in a lifetime of retention, you know, we just made him a night guard to serve as a protective appliance and as a retainer all in one. Let's go into our next case. We're going to pick up speed a little bit and go into cases a little bit faster. So here is a dentist who presented to my office, and he had 6 that he was unhappy with, basically a better looking smile. You know, his smile is not that broad. You know, his teeth are some retroclined appearance to him. Unhappy with the appearance of the existing restorations, but we also have some functional concerns. So this is where functionally driven cosmetic dentistry comes in. So, you know, if we take a look at his teeth and have them open up, you can see he's got a good amount of wear present on that lower arch. So maybe he's got some loss of vertical dimension. He's got an edge-to-edge bite, as you can see in this earlier photo here. So that's a concern, having an edge-to-edge bite, especially when he wants to have longer teeth, because where to get the room, it's long. So if we look at his problems list, he's unhappy with his aesthetics. He thinks he has a flat smile. He would like his teeth longer. He's got a worn dentition. He's got an edge-to-edge bite relationship. He does have some existing anterior ceramic, I'm gonna have to remove. And, you know, what about his vertical dimension? You know, if he's got his teeth are worn down, are we going to change his vertical? Are we going to do ortho? If we do ortho, where are we gonna move the teeth? Are the teeth still going to be worn? Is that going to let us have to not place that many restorations? So, you know, in talking with this patient, now this is a fellow dentist. So, you know, it's not just like talking to a patient on the street, and the person's well educated. You know, he's pretty much aware of all of his options and risks and benefits to those options. He understands them a little bit better than someone who's, you know, just an everyday patient. So I gave him 2 options. I said, you know, we can do and I would do your upper 10. I would increase your vertical in order to lengthen your and correct the edge-to-edge bite. Going to do it in the upper 10 alone when I increase vertical, that means I'm going to have to put full coverage restorations in place on his premolars. So we can wrap the anteriors and, you know, that pretty conservatively, but he already has restorations in place there. So that's not such a big concern. The bigger concern is handling the premolars in this situation, because that says we're going to have to prep them to some extent in order to have a longevity with our ceramic. Or, you know, option B. And option B was a dual arch treatment. So now, if I treated this in both arches, we can treat the upper arch with cosmetics alone and then increase vertical in the lower arch by stacking porcelain on top of the teeth. So by doing that, you know, that really allowed us then to have the option of a true no prep case here. The only preparation would be cutting off the existing restorations. You know, but the dentist did not want to deal with the lower arch. He did not want to add ceramics to his lower arch. You know, so he chose the upper arch smile design only. So, even though I'm dealing with a fellow dentist, I still felt here like, well, now I really want to be as conservative as possible. So really why I'm showing you this case is because I want you to unlearn maybe what you thought a full coverage prep had to look like. So when I'm doing a full arch case or even a single arch case, I get my pre-op model back, I get my wax up back. Next to that wax up, we can see here is that we have a reduction model that's in place, and that's a white model that has black magic marker, and that black magic marker is where I would have to remove tooth structure prior to putting his mock-up in place. And that's where we see that Siltec transfer that we're going to use, and then we have our reduction guides. So with a full arch case or the full mouth reconstruction, we can see that the top segment of this is an upper arch and the bottom segment is the lower arch. So, just to move on, we have a wax up, we have our reduction guides, we have our Siltec transfer that I'm sure you're used to seeing that. But likewise, in my cases, is I have a reduction model, and this reduction model with black magic marker is where we're allowed to reduce in order to form the wax. These models are not the doctor who I just showed you. It's a different case, but in this situation, this is how much I would have to reduce in order to put the mock-up in place. Likewise with that is I have this white, what looks like an Invisalign tray, and that tray is not what I'm going to use to put the temps in place. That tray is what I'm going to use to confirm that my pre-operative reduction is complete. So just to show you how this would look is you can see this is a different case. I put this clear plastic tray in place, but you can see that there's tooth structure basically binding, holding up that clear plastic tray. So that means I did not remove the black magic marker adequately because my transfer is not going to be correct. So once, and you can see on this, this canine here, you can see clearly there where the tooth structure is holding up that clear plastic stent. So once this clear plastic stent fits passively, I can then perform the mock-up and put the mock-up in place. Well, on this doctor's case, there was no black magic marker present. So what that meant is I can literally take his teeth as they are now, and I can just put his mock-up in place right over his existing teeth. So as I said earlier, on this case, I'm going to do his upper 10 teeth, and I increased his vertical on his 10 teeth, which means his anterior 20 teeth are in occlusion. His molars now are slightly out of occlusion. So again, this mock-up goes right in. And let's talk about some concerns that I know a lot of people might have about this. So one concern, he's got existing anterior restorations that we're going to take off. Not a problem. I think most of us can wrap our head around this. I think what a lot of people have a concern is that I'm opening the vertical dimension on 10 teeth. So if I'm opening on his maxillary 10, what's in his occlusion, again, is the opposing 10. So we have 20 second premolar, 20 dental arch. Okay. And what I want you to understand is when we open vertical dimension, every 3 millimeters that you open in the front, 1 millimeter between the second molars. So on this doctor, I only opened 2 millimeters. So 2 millimeters is really, you're looking at it like it's 2/3 of a millimeter that's separate between his second molars. It's hardly anything. It really doesn't even measure to a bolus of food. A bolus of food is larger than that. So it's literally, it's not comprehensible that there's that much space between their back teeth. But let's go into even the shortened dental arch, because some of you might have concerns about this. So if we look at all the studies, and there's lots of them, if you are bored tonight and you want to go down a rabbit hole, open up Google Scholar, and you can literally type in any one of these articles that I'm referencing, and you can look at the studies on the shortened dental arch. Now, the first article that I'm citing is Levin and Lorin, and it's dealing with dental implant failures. And what they did is within that article, they showed that after extensive review of the literature, Allah and Shyham concluded that to satisfy oral function, a complete dentition is not necessary. which is in accordance with others who suggest that middle-aged and older adults have sufficient oral function with 20 natural teeth and question to need to replace anything other than that. So, and really what they're getting at there is if you've had, implants in the molar region that failed, rather than going in and replacing them because there's a high failure rate to go back and doing a second surgery, you really should question whether or not your patient needs more than 20 teeth. And just let you know, the World Health Organization does not look at you as someone who has any disability unless you have less than 20 teeth. So the World Health Organization also agrees that 20 teeth, you're considered a normal individual. So we have tons of studies that go over this. The third study down is Armelini, and that goes over the shortened dental arch, a review of the literature, and that appeared in the Journal of Prosthetic Dentistry in 2004. And it's basically the summary of that is that there's really no issues with treating patients to the shortened dental arch. So we know that this can work out really well. So let's look at our other concerns. Our other concerns is how are we going to prep these premolars? Can we do no prep restorations on maxillary premolars? And really there's not a whole lot of literature out there talking about minimal prep and full coverage. And one of those was a paper by Robert Wake, and it talked about the effect of molar preparation, axial height, on retention of adhesively luted ceramic crowns. And this is basically a presentation at the International Association of Dental Research. And what he showed is, specimens, that's spelled wrong there, but specimens that had a 2 millimeter axial prep had the greatest resistance to failure, while specimens with a 0 millimeter axial prep had the highest failure. So I'm going to look at it. I'm going to at least want to have 2 millimeters of axial prep on my maxillary premolar. So we look at ideal preparation techniques. We want to see ideal arch forms, whether or not you use a 0.3 or 0.5 millimeter facial reduction is going to be a conversation that you're going to have with your lab. But we look at with incisal, middle, and gingival thirds, we want to see that. And then we want to have a 1.5 millimeter incisal reduction. So that mock-up that I put in place, this is me prepping directly into that mock-up. Now I know what you're saying. It's like, well, John, there was already ceramics there. Why are you doing this? And I just wanted to show is that like every case that I'm working up, this is exactly what I do. And I always take this picture because what I'm showing you in these photos is that how my prep design is going to be, it's going to be as minimal as possible. So it's basically allowing you to be as least aggressive as possible. Here are some burrs that I'm going to use. And, I just wanted to show you up there. You could take a screenshot of that, or you'll get that in my presentation. Those are the burrs that I use. But especially I'm being conservative. I'm going to use the burr all the way to the right, which is the 0.3 millimeter facial reduction burr. That's what I used in those 3 track lines that you saw facially. And then when I'm prepping a margin, I'm going to use that 856010, which is that first chamfer diamond that you see. It's an 010 diamond. It's extremely thin. And I'm not going to use the whole diamond in order to prep my finish line. I'm only going to use a minimal part of the diamond that I can detect with my loops. So this is, get great loops, steady hands, and you can do really minimal preparation dentistry. So when am I going to break contact? Closing black triangles. If a patient has interproximal restorations or decay, I'm going to prep interproximally. If I have to close a large diastema, I'm going to prep interproximally. Changing shades more than 6 or 7 shades. Changing the mesial distal width of teeth, like in crowding, would be a situation you want to prep interproximally. But this would be an example on a different case of a maxillary arch premolar prep where I was not breaking contact. And when I say I'm not breaking contact, I'm going to tell you I'm not breaking contact with my diamond. I'm going to show you how I do break contact minimally just to get the impression material in between the teeth, but very conservative. So this is what a prep design could look like in a maxillary arch. 2 to 3 millimeters down the lingual height of contour, so the lab can build back your functional lingual cusp properly for occlusal purposes. But on the mandibular arch, I'm just stepping over the top there when I have to prep. Otherwise, I might no prep the situation on the lower arch when I'm changing vertical dimension. So, this is me. I now remove the existing maxillary ceramics. But if you can look past the anterior 6, because the anterior 6 had restorations in place, and I just removed those as conservatively as possible, and then I'm just going to fine tune the margin there. But if you look at the premolars, there's no preparation done right now on the facial of the premolars. I prepped through that mock-up and I didn't touch the teeth. So that's showing us we didn't have to prep to get the final result, but we want to have, studies show we want to have some axial length to our prep in order to have strength to our final ceramic. So this is the prep design I'm going to do on this premolar. So that's that 010 diamond. And you can see from my margin, which is thin, it's nowhere near to be the size of that burr. It's only as thick as I can really detect it. And so I can pick it up in an impression to build back for the lab to have an area to go to and really have that axial contour built in. So here is the other premolars on the opposite side. I'm going to show you what I used in order to break contact here. So I'm going to basically prep above the marginal ridge. You can see here on the lingual, if you look in closely, I did not prep all the way down to the gingival margin on the lingual. I only prepped down about 3 or 4 millimeters. And if you look at the occlusal surface, it's not even touched. And how I'm going to break contact is I'm going to use that contact easy strip. I use the orange one, which has still a very fine finishing strip in between in order to break that contact. I'm going to zoom in on these photos in a second. Remember, the anterior 6 already had restoration. So my prep design there was dictated by what was already there by the previous doctor. But if we look at the premolars, we can see we have quote unquote full coverage, but I think we can all agree that those are not full prep. So where it's all in enamel. So, this all could have been done without any anesthetic, really minimal preparation, which I think we would all agree would allow these restorations to last for a long period of time. So here was his mock-up in place, or his temporaries in place now. So the preparation design was done, sent him on with his temporaries. He really liked how everything looked. We got to take this for an aesthetic and functional test drive to make sure that this was going to last for him. We built in guidance as shallow as possible on this case. And, here is an example of what my premolars looked like when the dies were ditched. So you can see I'm just basically kind of just prepped a little bit down into that marginal ridge. I'm not breaking contact with my diamond. It's just enough to have a positive seat on the ceramic that we can see there. So you can see how much vertical was added when we take a look at where my margin was to the existing tooth structure and now where the teeth are now. So here's where the temporaries were. Now here's where he started. Here's where he finished. And that was how that case ended up. Doctor was very happy. This case is really interesting because I want to show you what happened with this case and, really give you an idea of where else you can look at no prep restorations. So this was a young girl who came to my practice. She had already been restored in her maxillary arch. She was a bulimic patient who admitted to still being bulimic, and she wanted to have her teeth restored. So you can see her lower arch has a lot of wear, so we're going to restore her lower arch. So here she was in her temporaries, and she traveled a distance to my office. So we did like a FaceTime talk with how are you happy with your temporaries? How do you like everything? And she loved everything, but her only complaint was she thought her buccal corridor was too far out. And her quote was, "I think everything looks too perfect. And I really don't want it to be that perfect. I want you to bring my buccal corridor in." So because I disagreed with the patient, I actually made her come into my office. I made her travel down, and I brought in her buccal corridor to where she was happy. And then we replicated that. So, here's where she started. Here's where she finished in her reconstruction, which she was very happy with, until a point in time about 6 to 8 months went by. And what she noticed was the dreaded selfie. And everybody's in selfies nowadays, right? And what she noticed within her selfie, she called me up and she said, Dr. John, I have to say, she was like, you were right. It was a mistake bringing my buccal corridor in. She was like, because now what happens, not in professional photography, because in professional photography, when a flash is there, and not when she looks in the mirror, but when she does a selfie, her back teeth look like it's collapsed and she's not happy with it. So now I'm presented with a case where she already had full coverage before, and I cut those off and I put new full coverage in. I mean, how many of you would be happy to now have to cut off existing full coverage that you just placed, which, that brings some problems with it. You open up your patient to potential endodontic concerns, just a lot of issues. So, to me, I said, well, we have perfectly fine intact ceramics that are EMAX. How about we try to do no prep restorations and no prep veneers on top of that EMAX? So what we did here was, all I did in order to take this impression was I took a Brasseler intraoral polishing cup and I polished off the existing glaze. Took an impression of that, sent it out to the lab. So we took 2 impressions. Remember, every time it's no prep, it's 2 impressions. So I took 2 impressions of that, sent it to the lab, and now the lab fabricated no prep EMAX veneers to go over my existing EMAX restorations. So I'm happy about this because I don't have to cut off my existing restorations. We can see kind of how they fit over the existing model. But now you have the challenge of how do you insert this? This is EMAX. So Ivoclar has a product called Monobond Etch and Prime. So the last thing that you want to use intraorally in someone's mouth is hydrofluoric acid. It's extremely dangerous, but we have to porcelain etch these existing restorations. Monobond Etch and Prime is FDA approved for use on all ceramics. It especially works really well on EMAX. So I know if you're a CAD/CAM doctor out there, I'm probably preaching to the choir. You should not have hydrofluoric acid in your practice. This one bottle takes the place of hydrofluoric acid and your silane in one bottle, and you can use it intraorally. So I painted that over her existing restoration, scrubbed that in place for about 30 seconds, rinsed it off, apply adhesive, cure my adhesive, then put my cement in place. Now I'm going to do the tack and wave technique. Where once we do that, we have to, you're going to get interproximal cement. So a contact easy strip goes in to get rid of the interproximal cement. Then after you get rid of all your cement, after the tack phase, you cleared up all your cement, you put in your glycerin, like liquid strip, then you do your final cure. And then I'll say, here was this patient's selfie before, and here was her selfie after, and you can see that, I think, is a dramatic difference just from no prep restorations on top of existing porcelain restorations. So where before they said it couldn't be done, now I think with what's available to us with our technology and our materials, we can do cases like this. Wrapping up with a couple more cases. So hopefully you're having fun talking about this. This is a 15-year-old young girl, comes to my practice. She was referred to me after she completed orthodontics. So she's 15 years old, and you can see she has mal-shaped peg laterals. And there's also in the literature, you can see that she has what's similar to peg centrals. So she has undersized centrals as well. It's kind of funny, when dealing with patients, I kind of always ask my patients, how would you rate your smile on a scale of 1 to 10? And, this young girl came in and I said, can I ask you, how would you rate your smile on a scale of 1 to 10? And she was like, are you kidding me? I hate to smile. And that's really all I got out of her. It's kind of felt like I put my foot in my mouth, asking her these questions. So, this patient's unhappy with her aesthetics. And I'll tell you what's really more important. The mom is concerned that, her teeth are causing her emotional stress, because the mom told me that, some of the people in school called her shark girl. People get bullied, and, it's really a terrible thing to have, teeth like this. And, we could do some things about it. So some other things that are problems. So she's got peg laterals, undersized centrals, and she has large diastemas. That's a concern as well. So we talked about some treatment planning options. Now, orthodontics is not going to fix peg laterals and peg centrals. So we really only have two options. And plus, she already had orthodontics to set up her arch form. Let's remember that. So she can either do resin restorations or porcelain restorations. So, here's where a concern is, because, and I'll tell you what, I've drawn heat about this case before. I've gotten criticized for, even presenting the option for porcelain restorations on a 15-year-old girl. But I really want you to think about, what do you have to do to these teeth in resin or porcelain to get proper contours, to prevent from having overhangs, and really to give this person a really good long-term result. Now, this person's going to go off to college. Does she want to have, chip a resin restoration, be afraid to chew on things? So I presented equally. I gave pros and cons to each one of these, and the mom and her chose porcelain restorations. So here's the mock-up in place. Again, that white model had no black magic marker. So I basically put the restorations, the mock-up in over her existing teeth. You can see with the diode, I did some gingival recontouring because her peg laterals were not, did not have the same gingival zeniths. But when I prepped into that mock-up, I did not touch the tooth structure. So, but when we look at this, still she has diastemas. So what does that mean? If she has diastemas, you do not want to have a ledge of porcelain or composite. So you're going to have a small finish line in order to prevent those two from happening. So here we have a minimal prep, restoration. And again, anytime you're trying to close space, you're going to have a finish line. So no prep restorations are contraindicated with large diastemas. And this is a case where there's large diastemas. So you can see really my only margin was a really small finish line. And to show you how small it was, I did not even use that 010 diamond. I actually used what you would use as like a flame polishing diamond in order to prep that margin. So here was her start and here was her finish. Now, really what I also want you to notice about this is every time she came in throughout her treatment, she always had a hat on. She had her bangs in front of her face. And really, to get her to smile in this picture, it took a lot of coercing. It literally was like and she didn't even smile for me. She would only smile for a female assistant of mine in order to get her to do that. But I want you to see even the change in her appearance. Even though her head's a little bit cut off, she came in, she got her hair cut. She no longer wears her bangs in front of her face. She never wore a hat ever again to my practice. And I really think, because of doing these all ceramic restorations, it really allowed her to change her life. One of the last cases I'm going to show you is here's a hygienist who presented to my office. And she was unhappy with her teeth. She did not like how they looked. Even though her teeth looked pretty white and look pretty good, she has some concerns about them. So if we look at her problems list and how she brought it up is that she was unhappy with her aesthetics. She wants longer, whiter teeth. She's got a reverse smile that you can see even in that cropped out photo. She has slightly retroclined teeth, which no matter how white you bleach, as I said earlier, when teeth are retroclined, they're always going to look darker because they deflect light. Her teeth were retroclined because she had bicuspid extraction and retraction orthodontics done as a teenager. And then she even had Invisalign treatment in her late 20s prior to coming into my practice. So she had orthodontics twice, and she's still unhappy with her reverse smile. So the treatment options we presented to her was orthodontics for a third time and maybe bleaching to hopefully try to, erupt her maxillary centrals. to try to change. She didn't like the embrasures spaces in her canine. She thought her canines looked too sharp. She actually said at the time this case was done, I look like I should try out for the show True Blood, which is a show about vampires on HBO. So she didn't like her teeth. But so a lot of things are not going to be corrected by doing orthodontics a third time. And the second option was to do no prep restorations on her. So she chose no prep restorations, and here was the end result: lengthening her teeth, changing the shape of her canines, correcting the buccal quarter, and basically giving her now a smile that files her lower lip and is no longer reversed. Now, I will tell you, there are some issues with no prep restorations because that case is now about 10 years old. And here is that same patient like I just showed you. Here are her no prep restorations now. They're not failing. There's no bond failure. But what we see from the tooth structure underneath is that her tooth structure underneath now looks a little bit darker. So potentially, long term, she may have to bleach her teeth now and again to prevent that underlying tooth structure from showing through. Otherwise, you would have to replace them. But there's no reason to replace these restorations when they're intact, they're healthy, everything looks really well. So just a matter of long-term bleaching is a solution. So I just want to thank you very much for sticking along. I think we're at the hour and 20-minute mark. So we have a few minutes to handle questions. And really, even before we even handle questions, I just want all to say, this is my last bit of message: stay positive. A lot of people are focusing on negative throughout these times, and really you want to focus on what you can control. Set a daily schedule, but always be positive. And I want to thank you before we get into the questions for taking your time and listening to me speak tonight.
Dr. Nosti, thank you very much. Again, enjoyed hearing this presentation. It was fantastic in Chicago, and you did a great job delivering it from your couch there. So we appreciate it.
Thank you so much.
For those of you that are on the webinar today, after we're done with the Q&A, we're going to put up a slideshow that just features our upcoming speakers for next week. So let's launch into this. Do you have any recommendations for a photo documentation course? I have problems taking photographs, especially for shade.
Yes, so there are some online courses on Dentaltown. I know Jason Olitsky gave an online course. Lee Gary, who speaks with Clinical Mastery. There's actually going to be an online course on online.clinicalmastery.com that has it. But besides from that, and we also teach that in our curriculum, but besides from that, a lot of times, if you attend one of the AACD meetings, there's typically someone always speaking on photography at the AACD meeting. So those should be some good resources for you.
I'll also add that Dr. Jason Kim did a wonderful webinar for us about a week ago on shade matching. So that's available on the Washington Academy of General Dentistry on the YouTube there. Okay.
Perfect.
How do you sufficiently lengthen anteriors without opening video on posteriors on moderate to severe wear patients?
So how do I open vertical dimension on anteriors?
So how do you sufficiently lengthen anteriors without opening video on posteriors on moderate to severe wear patients?
Okay, so in the case that I showed, I did open vertical. So in a lot of cases, you're going to have to change vertical on severe wear cases. So I wouldn't just lengthen the anteriors without changing the vertical dimension in the posteriors. Hopefully that answered your question. But what I would look at it in terms of, if you don't have wear into dentin on the maxillary premolars, like that dentist didn't have wear into dentin on his maxillary premolars, but we had to change vertical. And That case that I showed you with Lou, the first case, he had wear into dentin on his maxillary anterior 6, but no wear on his premolars. So I did not have to change vertical on him. So a situation could be that you would do orthodontics on an anterior segment alone. You would create a reverse smile like I did on Lou, and then you can add back the length of the teeth without having to touch the premolars, or maybe just adding facially to the premolars if the premolars are not affected with wear. If the premolars are worn, we're going to change vertical dimension. But hopefully that answered your question as you asked it. If not, you can also email me at what you see on the screen.
Yeah. And thank you for providing your email. That's very kind of you. Do you work with a variety of labs and manufacturers currently, or predominantly lumineers?
Oh, so I do not use lumineers. So hopefully let's understand that. The reason why I showed lumineers was just because that was like the industry standard, as I see Dr. Hess nodding his head for.
Yeah.
That was just the industry standard for no prep. There was really no such thing as no prep. It was lumineers. So my whole beginning was just really talking about the history. So the labs that I use are Gold Dust Dental Lab, predominantly out of Phoenix, Arizona. But I have done a couple no prep cases as well with Nelson Rigo and Rigo Smiles. Those are the cases that I showed. So all of my cases, I showed you the lab who did them afterwards with their logo. So I do not use lumineers at all.
Okay. Tell us, what were lumineers? What was the material?
Serenate porcelain was the material. So what's really interesting is if you want to try to look up literature, go to PubMed, go to Google Scholar, and you can try to look up any really referenced literature on lumineers. And the only publications you will find, there's no actual studies done on the ceramic. The only publications you will find will be in things like Inside Dentistry or Dentistry Today, things like that. It's not a true research article on wear compatibility, marginal adaptation, wear rates, any one of those, shear strength, none of those, there's no studies on it at all. So that's another reason why I would shy away from it.
Okay. What was the $1.25 plastic jig Facebo record again?
Okay, so the $1.25 plastic jig is a part of either the Koi's facial analyzer, or if you don't have one of these, I would tell you to take a look at the company called AD2. So like American Dental, then 2, just ad2.com. And what AD2 has is they have the same thing as the Koi's Facebo, but it has a laser on it. So with the laser, you flip a switch, it puts a laser crosshair on your patient's face. It's a lot easier to tell whether or not you are parallel to the interpupillary line and if you are on the midline. So, and that can be used with the Panadent articulator. It can be used with the AD articulator. And labs like Gold Dust Dental Lab have a mounting jig that you can also use it with, Hanau, Stratus, and even, the articulator, I'm losing my mind right now, that the Spear Group recommends.
The SAM articulator.
The SAM, correct.
Yeah.
So they basically have a jig that they can mount any one of those, or take that plastic jig onto any one of those. It's a great way to do cosmetic cases.
Yeah, they've really filled the gap in there between articulators and Facebos. All right, why did you want upright teeth?
So the reason why you want upright teeth, and hopefully you can still see my screen, and me, upright teeth, if there's just upright, it allows you then to add to that tooth facially. Because if teeth are already proclined in the proper position, how are you then going to add material or ceramic on top of it? The teeth are going to look way too big and they're going to be way out of position. So you want to have either just upright teeth, or you want to have teeth that are slightly retroclined. That's going to give you the lab space to add the material without having to prep tooth structure.
All right, in the second case, the patient shows mandibular anterior wear. You mentioned he had preoperative porcelain restorations on the maxillary arch. Is this the reason for the wear? How do we avoid this in the future? Is option B the only option for this?
No, I personally don't think that, you know, his porcelain alone caused his wear. I mean, really this person, it was the occlusion that was there ahead of time. It was a parafunctional habit of bruxism. And, you know, if you look at his teeth were shorter. So he probably even did wear down that porcelain that was there a little bit as well. So I think it was a multifactorial that led to his teeth to look that way. As far as option B, you know, it's not that his only option is to put porcelain back over that, but you really have to think about it. You know, if the long-term discussion was you have teeth that are worn into dentin and, you know, you have to protect them, and they are more susceptible to wear than teeth with enamel or porcelain on them. So that's what I just want to say. Like, you do have options. I just did his maxillary arch. That was an option, you know, but it also comes with some potential long-term consequences. And that is further wear in the lower arch that, you know, down the road, you know, the options that we have to treat it now might not be the same options that we can do later on. So, you know, when our goal is to try to be as conservative as possible, you know, I really thought no prep restorations in both arches would be the best option, but, you know, he thought otherwise.
Do you teach veneer courses?
Yes, we do. In clinical mastery, I teach an over-the-shoulder reconstruction course. It's basically in the op where you come and in 2 weekends, you see me do a full mouth reconstruction. And then as under our clinical mastery umbrella, Jason Olitsky teaches a 1 weekend in the op veneer course. You know, my full mouth reconstruction course, you see 1 patient from start to finish. It's 2 weekends. And Jason's course, he lectures, he preps a case. The next day he lectures, he seats a different case. You know, Jason at the time was the youngest dentist ever to be accredited in the Academy of Cosmetic Dentistry. His practice in Ponte Vedra, which is near Jacksonville, Florida, is really only focused on cosmetic dentistry alone. He's an unbelievable educator in the field of cosmetics. So you can check that out at clinicalmastery.com, and it's the in the op anterior aesthetics course.
All right. Why do you need 2 sets of impressions in a no prep case?
Great question. So the reason for that is that's what the lab wants. And the reason why is so they are building the ceramic on one of the working impressions, let's say working models, but then they can test it out, the fit on the second model. Because basically what the lab is doing is they're doing a try-in before it gets to you just to ensure, because of the multiple firings that they are doing and sometimes shrinkage of the ceramic, they're making sure that it's absolutely going to fit before it comes to your practice. That's why the lab wants 2 separate impressions to fabricate 2 separate working models that just makes them a lot more accurate for you.
Okay. If you have to increase vertical dimension of occlusion, how long do you keep them in the mock-up?
So what I would say is that's totally up to you. So you can, you know, whatever your experiences is. Like my experiences, I place the mock-up, and that day I start doing their work. I start prepping them. I put them in temporaries, and I'll leave them in temporaries for a month to 2 months. The only time I'm leaving them in temporaries longer is if they have a temporomandibular joint disorder where I'm worried about the occlusion changing over long periods of time. Those patients are then left in that temporary, let's call it a living splint. They're left in that living splint for a time where I no longer see occlusal changes, or I do not have to adjust the bite. So once that time frame has happened where I've stopped adjusting the bite, I'm not seeing occlusal changes, I then wait 3 more months. Or if they have pain, if I've got them out of pain, I wait then 3 more months. So the least amount of time I'm waiting in a TMJ patient is 3 months, and that time could be a little bit longer. But if you're worried about your patient being stable because you changed vertical, there's really zero concerns with that. And you can leave them in that, let's say, that living splint for only the amount of time it takes for your lab to fabricate the ceramics. Hopefully that answers that question.
Are you using impression cord? And another question about what impression materials are you using?
So and I only use cord if my margin has to be subgingival. So the majority of my all ceramics, my margin is at the gingival margin, so I'm not using cord. If my margin is going to be subgingival, like an active bulimic would be a situation like that case I showed where my margin is subgingival, that's where I'm placing cord. And the impression material of my choice, I love 2 impression materials. And I'll tell you why I love 2 impression materials. If you're already really good at taking impressions and you want like maybe a new material that's more cost effective, my recommendation for you is to check out Kettenbach's material that is a part polyether, part vinyl VPS, and that's called Identium.
Yeah.
That's a great material. I love it. If you're someone that you have to take multiple impressions in order to get a good impression, then I will tell you that you should check out Ivoclar's Accudent XD is their material. That is a really good impression material.
Absolutely. Does swishing any carbonated beverages such as Perrier or carbonated water cause the tooth wear on the lingual of anterior, or just beverages with sugar? Sorry, I put up.
No, I got, so if you look at my presentation, I showed you a picture where I put a circle on teeth, and right dead center in the tooth, like at the gingival, there's like a circle. Let's call it an island of Denton. That comes from switching carbonated beverages. So switching beverages is going to be a facial only, not really so much of the lingual, at least what I have seen. So LaCroix, any one of those beverages that you're switching, those are, they do have really high, really low pHs, I should say high acidity levels. So you can see that. Anything that's on the lingual, to me, that's either going to be, it's going to be something that's going to be intrinsic. It's either going to be from bulimia or it's going to be from GERD. And just a real quick synopsis on how can you tell the difference between those two. For the most part, now you can't say always, you can't say never, but for the most part, GERD is going to affect the lower arch, where for the most part, bulimia is not, unless your bulimic patient is so severe that they've developed GERD, like what I showed in that case earlier. So because when you vomit, your tongue comes out of your mouth and over the lower arch, and it protects it, and the maxillary arch takes the brunt of it. So hopefully that helps with you.
A question about patient sensitivities to dental materials like Siltec filled with Luxatemp. Apparently they had a patient that ended up that looked like herpes of the lips after they used these materials. Any thoughts?
Yes. So that most likely is allergy to the monomer in the bisacryl. So my recommendation, if you have that, is you check out a material from Kettenbach called Visalis temporary material. Now, it is not a bisacryl. It has a different monomer type in it. It's almost like a dual cure composite. So I would check that out and see if that works on your patient and solves that problem for you. It's also, it's a really strong material. So if you need a temporary on a patient, let's say, who's having extractions done and implants and grafting, and you have a temporary that needs to be in there for a long period of time, and you're not going to do a lab fabricated temp, Visalis temp works great in those situations. Again, it's by Kettenbach, and it's really cost effective as well.
All right, I'm just going to give a shameless plug here, Dr. Nosti. For your students out there, Crown Prep 101, August 15th, at the we're going to be doing walking you through Crown preparations, and Kettenbach is one of our sponsors, and you'll get exposed to both of those materials that Dr. Nosti mentioned, and the Visalis provisional material as well. Sorry about that.
That was good. Loved it.
All right. By uprighting the maxillary anteriors, are you worried about constricting the envelope of function?
So if you say by uprighting, by pulling them in, potentially that could be an issue. So for the most part, like on Lou's situation, you know, you're talking about minor movements, and he had diastemas. So you're not talking about a case where you would have to do interproximal slenderization in order to retract the teeth. I would not recommend doing that. That would be a situation where you could potentially cause harm to the envelope of function. In situations where you have diastemas, there's typically room to retract. If there's not room to retract, that would be a situation where you looked at with Lou. There was also the lower arch was treated. So in the lower arch, he also had some spacing there. We brought the lower arch in there as well. So that is how we got past, you know, worrying about the envelope of function, because it was a dual arch orthodontic treatment. But yeah, it's a great question.
So for Lou's case, was it restorations from number 2 to 15?
It was actually second premolar to second premolar. The upper 10 were done.
Okay. Do you prefer pressed Emax or CAD/CAM milled Emax?
Oh, that's a great question. So I will tell you, I have done more pressed Emax because early on, the literature early on showed superior strength in pressed. So I will just tell you, I have placed more pressed than I have CAD. But I think that's changing. The tide is changing on that. And I do place some CAD Emax now as well.
What's the difference between using Excite versus Adhes Universal?
Ooh, great question. So the only difference that I have found, and I actually want to take that back. There really is no difference. Let me tell you that the reason why I still use Excite on a lot of my cases is just from the fact that, you know, I've been in practice for 22 years. I've been using Excite since 2005, maybe even earlier than that. So I at least have 17-year history with Excite. Adhesives newer to the market. It's been around for actually quite some time now, but it's newer than Excite. And I use Adhese in all of my situations where I'm using a dual cure cement, like Verilink Aesthetic Dual Cure. Adhese also is my bonding agent when I'm using the Power Cure system from Ivoclar and PowerFill, which is basically a bulk fill posterior composite that cures in 3 seconds. So I use Adhese for the selective etch technique in my posterior direct composite. So I etch enamel, and then Adhese is a self-etching bonding agent. So I just paint that on the dentin and then, you know, air thin that and cure it. And that's got super high bond strength. So Adhese is really a bonding agent that does, it's like an 8th generation bonding agent. It works in self-etching mode. It works with dual cure composites. It's really great. Where Excite, you have to etch prior to. And why I still use Excite is just because I have such a long history with Excite. But if you haven't had the history with Excite that I have, I would recommend using Verilink Aesthetic Light Cure, which is the cement material that I use for my veneers. The adhesive bonding agent comes in the kit. I have used it with some veneers. I will not say I haven't. I have used it. I've probably used it at least 20 cases so far, but I have not used it on thousands of cases like I have Excite. But it works great.
Okay. Thank you. Is that clear matrix just a suck down of the wax up?
Yes, it is. And the benefit is you don't want to use that to transfer your temporaries to, because that will stick to your temporaries. So that's where the Siltec comes in place, because that soft is going to give, you can tease it away, and you're not going to pull off your temporaries, especially in a no prep situation. You'll never be able to. I know some labs tell you to use that clear plastic stent for your temporary transfer. That will never work in no prep situations. Ask me how I know that one. But go to the Siltec, but that's all that is, correct.
Okay. Can Monobond etch and prime be used on any ceramic?
I have used it on every and any ceramic. Situations where patients had existing PFMs and they were going into orthodontics, I was able to bond orthodontic brackets on PFMs using that, and the bracket did not come off throughout their orthodontic treatment. So to me, that was really the game changer, where I looked at, you know what, I can do no prep restorations on top of ceramics if I can bond an ortho bracket onto a PFM where that ortho bracket is consistently under tension, torsion, strain, all of those things. And, the wire's trying to pull the bracket off and it didn't come off. So yes, you can.
How do you cement temporaries, and do you make them chair side?
So majority of my cosmetic cases, they are done directly in the mouth with the shrink to fit technique. I'm going to tell you, that could be like a 20-minute discussion on all the steps that I do.
Yes.
That's what I'm going to tell you. It's free. Just go to Dental Town, sign up. It's free. Go right into the cosmetic section. Look up under the shrink to fit technique, and it details in photos, lots of words, all the products that I use, and it details it really well on how to do that technique.
Okay, let's combine a few questions here. With prepless veneers, where and how do you end the ceramic? Do you still need a finishing line? How thin are the minimal prep veneers?
Great questions. So with no prep, the finish line is really dictated by the lab. So I've had restorations where the patient's teeth are really bright and it's only like a half a veneer that gets bonded onto the patient's tooth. So, it's kind of like it's dictated by the lab. As far as thickness goes, it's as thin as the lab can finish it down to. So in pressed ceramics, that last case that I showed of the hygienist, she had Emax no prepped restorations. They were 0.3 of a millimeter thick. And so really what dictates how thin it can go is your lab. And it's your lab's willingness on fabrication. So some labs will tell you that it has to be a 0.5 millimeter to 1 millimeter, but some labs, like, those feldspathic restorations, they're thin, 0.2, 0.3 of a millimeter.
What are your post-op instructions for no prep veneers?
Same thing as all of my other restorations, and they are: do not use your teeth as tools. You do not want to bite on anything hard with your front teeth. Like, you don't want to take a hard granola bar and torque your front teeth with them. But I have veneers. I mean, I use my front teeth all the time. I bite into sandwiches and things like that. So it's not really a huge concern as much it is as don't use your teeth as tools. Don't bite your fingernails. Don't chew on any objects. And then, for the most part, we do, on many of the no prep restorations, fabricate a nocturnal parafunctional appliance.
Are you worried about porcelain fracture when doing veneers on wear patients?
No. So let's say, even though this title, this presentation was called veneers, if you looked at it, it's really about all ceramic, anterior all ceramics. So, you know, am I worried about the restoration? It's really going to be like, what are we doing different to that restoration than you would, let's say, a conventional restoration? So let's talk about wear, you know, real quickly. If you have a wear case from attrition, not from erosion or bulimia, because that's not a parafunctional issue. Attrition is the real issue that you're going to, you know, talk about fracture. So if you have wear from attrition, that's where, for the most part, I'm using Emax. And unlike a conventional cutback and layered technique, this is one of the benefits of Emax. The lab can do what's called a micro cutback. And that micro cutback is only on the facial incisal third. It's not completely through the incisal edge of the ceramic. So now what you have happen on the lingual surface of their tooth, when the patient's going into guidance, the whole lingual and whole incisal edge is going to be monolithic. It's only this really facial portion out here that's going to be cut back and layered. So the only time your patient's going to break that is if they have an outside in problem, meaning they take their lower arch, jut it out, and now they pull back against their incisals. That's the only time that you're really worried about that. And from my experience, that's not a nocturnal issue. That's a daytime issue that I see a lot of patients have because they do that during the day. Some patients might do that at night, but you can protect it with a nighttime appliance. But it's more about talking to your patient about changing their daytime habits and making them aware of it. But doing that micro cutback really is going to prevent fractures from happening. Now, I've placed a ton of Emax restorations, so many that Ivoclar asked me to write a professional synopsis of the literature on Emax, because I have literally tens of, I don't know if tens of thousands, but at least 10,000 Emax restaurants. I have a ton of Emax placed. So if I look at using Gold Dust Lab as my primary lab since 2005, my remake rate on my cases is less than 2%. So if you consider placing a lot of restorations on a lot of wear patients, that's not a whole lot of fracture rate. So the long story that short is I'm not worried about it based upon building it to protect it, designing the ceramic the correct way, conserving as much enamel as we can possibly, and then protecting it at the end result. Those things should really minimize porcelain fracture.
Beautiful. We're gonna. You've been very generous with your time on the Q&A here, so they keep coming in. We're just going to hit you with two last questions, and then we'll let you off the hook. In the case of the dentist, did the posterior molars couple in the end?
By now they have. So his case is about a year and a half old. So, you know, if you open up 3 millimeters in the front, 1 millimeter in the back, by the time you get a combination of condylar seeding on cases like that, and then within a year, you typically get super eruption. I hear people say you're worried about super eruption back into interference. I have not seen that happen, so they'll just come back into contact. But his molars did finally come back into occlusion. Good question.
All right, finally, do you use any digital scanner for cosmetic work, or do you still use impression materials?
I still use impression materials because when you do not break contact, you cannot use a scanner. So still to this day, impression material is king. Awesome question.
Absolutely. I agree 100%. Again, I want to thank you, Dr. John Nosti. A beautiful presentation. Thank you for donating your time. We're going to let you off the hook here. If you stop sharing your screen, I'm going to share my screen and just share our upcoming webinars. And
absolutely.
Thank you.
Sorry about that.
And on behalf of the Washington Academy of General Dentistry, Val Bartoli, Gary Hayamoto, and myself, thank you everybody that's attended today. We appreciate it. You will receive CE credit in the next couple of days. And you will also have those credits submitted to the Academy of General Dentistry. So with that, we just want to say from the WAGD, stay home, stay healthy, and please enjoy the CE. We've got a great lineup next week that includes our good friend from Croatia, Dr. Starcevic. He's going to be speaking on prepless veneers also. So this is going to be kind of interesting to see what his take is. We've got Janice Hurley, Ian McNichol from Wheel Media, Dr. Fling from Pankey. We've got Michael Giardino from the University of Washington talking about update on periodontal classification. And a good friend, Dr. Tazir Suleiman, is going to look back at 30 years of bleaching and talk about where we are now and where we've come from. So if you're interested in any of those courses, please use the QR codes. If you see somebody that's going by in these flyers that you missed, please go to the YouTube to Washington Academy of General Dentistry. You'll be able to catch a copy of their presentation on there. For students and young dentists, I want to remind you, we're hosting Saturday, August 15th, the Crown Preparation 101 course that's sponsored by Bean Air, Comet USA, and Kettenbach. Some of those materials that Dr. Nosti mentioned, we'll be utilizing those. It's a lot of fun. It's not just about prepping teeth. It's taking a systematic approach to those restorations, right from seating the patient, explaining what you're doing, to releasing the patient and doing post-op. So we're going to let this slideshow run. I'm going to mute myself. But again, Dr. Nosti, take care.
Thank you so much. I appreciate you.
Thank you. Great presentation. Stay safe.